Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Maranda Ward. She is a clinical research assistant professor. Her Kevin MD article is titled, Why HIV and COVID-19 Vaccine Screening Should Go Together. Maranda, welcome to the show.
Hello, and thanks for having me. I'm really looking forward to our discussion today.
We'll get into your article in a little bit. First off, briefly share your story and journey to where you are today.
Yes, so as a Black woman who grew up in urban America, I really care about how the health workforce is trained to care for the communities that I represent. And I also care about how faculty are trained to teach about the communities that I'm from and how programs are designed to include and support students who look like me. So basically, it's really my identities that explain, my interest in really amplifying the voice of those who live in historically disinvested communities. And that also includes brown folks and queer folks and, systemically excluded students in health fields. So yes, I'm engaged in anti-racism work. I'm engaged in diversity, equity, inclusion, justice-based work. I don't get to just hang that up when I get home or wait to think about it when I log in for a meeting. I'm always either experiencing or observing threats to justice, including in my own healthcare. And that's why I teach and I design curriculum and I administer programs as an assistant professor, as a community engaged scholar, as a director of equity in the work that I do at GW in the School of Medicine and Health Sciences. But if I just back up a bit, I did want to say that my training is actually in sociology and anthropology, which does include an undergraduate degree from a small liberal arts historically Black college for women. Yes, the illustrious Spelman College. But my training is also in public health with a maternal and child health graduate degree from Tulane. And my doctoral degree is in curriculum instruction from GW. But these degrees, they don't protect me from discrimination, from mistreatment, and again, is explaining why I'm so committed to preparing the health workforce to address the challenges of both health and racial equity, and basically translating my research and training on health disparities into process. And so I'm especially interested in really challenging the narratives about Black and brown communities as it relates to why we're disproportionately burdened by the HIV and COVID pandemic specifically.
All right, so we're going to get into that a little bit, but let me ask you, when it comes to disinvested populations, like you mentioned, and you are involved in the education of future healthcare professionals. So tell us, what more needs to be done? What can we do to better educate our future healthcare professionals?
Well, first off, I think it's all about framing. I think that it's really important to really understand that, we really are never going to eliminate health disparities without first eliminating racism. So, I think that when we talk about health disparities, there's a tendency to always focus on what individual patients need to do. Health disparities actually don't exist in individual people and patients. They exist across entire populations, and it's pattern. These are trends, and it happens to be that the only populations that even experience health disparities are the ones that are socially disadvantaged. So we know it's not natural. We know it's structurally engineered, and so we know that we need to be having conversations about the role and impact of racism. And I know that when we talk about things like COVID, especially COVID vaccines, participating in clinical trials, there's a tendency for us to focus on vaccine hesitancy, and I'm intentionally using air quotes, and I'll talk about that in a minute, and even medical mistrust. But what we really should be talking about, again, is racism. And so I think that, ultimately clinicians cannot afford not to have a racial equity lens, one that's, intersectional in nature, but they can't afford not to be engaged and care about, anti-racism and policies and practices that are anti-Black or anti-people of color.
All right, let's talk more about your Kevin MD article. It's titled, Why HIV and COVID-19 Vaccine Screening Should Go Together. So tell us, how did this article come together?
So believe it or not, the similarities between HIV and COVID are not as intuitive for some people, right? So this is why I wrote the piece and entitled it, Why HIV Screenings and COVID-19 Vaccine Screening Should Go Together. Because in the article, basically, I'm focusing on why, PCP specifically should be actually addressing these two very stigmatizing health disparities as part of their standard screenings that they offer day to day. And so this explains why in the article, I'm really emphasizing the importance of having screening conversations with all patients. And the reason why I say this is because right now the CDC HIV screening guidelines suggest that PCPs ask patients between the ages of 13 and 65 at least once about their HIV risk and therefore getting a test. But the inherent flaw in that guidance is that risk doesn't work like that, right? Risk behaviors need to be addressed on an ongoing basis, not just once in the span of somebody's life. I mean, it literally takes one decision to get exposed to HIV, but that's not just it, right? The current HIV screening guidelines do focus squarely on risk, or should I actually say on a PCP's perception of your risk. So that means that a patient older in age or a patient that's in a 20-year marriage may actually be assumed as having no risk, and therefore be a missed opportunity to actually get tested. And what that does is it actually opens the door for profiling of patients, whether it's intentional or not. And we know this is not about intent, this is about impact, and impact is real. So patients, they're just oftentimes being cherry picked by PCPs for who they believe are at risk, and therefore, who they should take the time to ask about HIV testing, rather than posing a set of standardized questions to everybody whose risk and not their bias is actually the reason that they're getting tested. So this current guidance and the practice of this guidance really, in my opinion, maintains stigma. And Black and brown patients have told us through my research that they actually feel offended when a PCP asks them about HIV testing, just what feels like out of the blue. And this is why it should really be couched as a set of questions about sexual activity, and depending on how you respond will determine if the PCP brings up HIV testing and PrEP. And the one thing I also want to note is that if a patient actually lives in an opt-out state, like I do in Washington, D.C., it's actually the role of the PCP to share that, say, what, today we're actually just going to go ahead and run an HIV test unless you, don't want to do that. That's really important, because right now, I have yet to have a PCP actually be really forthright and actually tell me that. And I know that I've been tested for HIV because I always get my LabCorp bill and I read everything that I'm being charged for. I look at my patient portal, I'll see all the labs I run, and HIV testing is always amongst them. Now, trust and believe, I have no problem with being tested. I promote testing. And I also believe in informed consent. And so do the patients who've enrolled in our study, who tell us they want PCPs who are going to be transparent and explain all the tests that are being run. So basically in the article, I mentioned how, HIV stigma alongside with COVID stigma and why it exists, and how that kind of gets baked into like practices like that. And so it's just really important that, there's open, honest, and ongoing conversations about both.
So tell me, in your ideal world, tell me how that conversation would go when it comes to addressing HIV screening. So like, obviously you have an audience here of primary care clinicians. So how would you like to see it done? Just to give us a case study or an example.
That's a really great question. I mean, I would say that, the thing is that when we talk about PCPs and patients, we're talking about having rapport, having a relationship. Right. And so, I mean, on the one hand, we need to actually have patients establish a medical home, and then actually have a PCP that they see the same PCP so they can have that relationship. And then when you have that relationship, of course, you can start posing questions about, oh, are you sexually active? And, when I say sexually active, what does that mean? Right. And instead of just saying, have you had sex? And then, relying on someone's interpretation of what that means. So again, it's like, making assumptions, you're asking them. And then when they start to tell you, like the forms of sexual activity they're having, it's like, okay, well, and then that will, will kind of trigger to the PCP that, oh, look, they mentioned this form of sex. Maybe they're, being exposed to this particular fluid. Right. So then that's where you can start to ask a higher level of questions, related to, whether they would be a good candidate for PrEP, for example. And we know PrEP, obviously, it's for patients who are HIV negative, but are, potentially having sex with people who are exposed to HIV or have HIV. So then, when you were having those conversations, it'll come out in that way. And actually, believe it or not, so next week, actually on Thursday of next week, we're having a grand rounds on culturally responsive communication. I'm literally moderating this discussion with two clinicians. One's a PA and the other's an MD. And they're going to be talking about specifically what they do in their practices to do just this.
So tell us more about that connection between HIV screening and how that would lead to improved COVID screening.
Well, so I guess what I'm saying is it's not that one type of screening is going to improve the other screening. It's the fact that both HIV and COVID are stigmatized, highly stigmatized, right? And both HIV and COVID disproportionately impact the same patient populations, right? So given those similarities, it makes sense that, okay, we know that there's the overlap there is that there's lots of misinformation, there's myths, there's, then we already know that we're in the era of disinformation and people not believing science and things like that. So for those reasons, it just makes sense to talk about these two very stigmatized infections in the same visit. So it's not to say that, oh, if you do one, then automatically you'll do the other. It's just saying that there's so much overlap and parallel between the two that it makes sense to talk about them both. And when I say COVID, I realize that a lot of people are getting COVID vaccines outside of the primary care setting, in community settings. So that's why we're not saying, oh, you should talk about, the like COVID treatment and COVID care. It's just posing the questions about, do they actually have the COVID vaccine? Do they have the booster? Because it's, this is the place to talk about prevention in the primary care setting. And then, moving into where they can go if it's not at your clinic. So hopefully, and that's actually one of the things that some of the PCPs in our research did mention is that, like why even bring up COVID vaccine when I know that my clinic doesn't even offer them? Like I'll do all that time answering all their questions and maybe even convincing them that they'll, this vaccine will offer them some level of protection, just to be like, oh, well, here's a list of places to go because we don't even offer it here. So now it's also like a barrier, so I realize there's clearly policy implications for what we're, promoting. And that's why literally in the work that we're doing, we're doing research, we're doing, offering some policy recommendations, but we're also doing some social, like some advocacy messages, because we need to make the case for the value of even doing this in the primary care setting for PCPs, since they're so inundated with like all these things that they have to do and remember, but then also for what patients can do too, because I'm not putting this squarely on PCPs. Patients also can pose questions that they have about, HIV and all the things they heard about how you get it, how you can't get it, and same thing with COVID, right? So I think it's definitely, a shared responsibility.
So one of the things I said earlier is that one of the ways to tackle the disparities that we have in healthcare, sometimes you have to see things through a racial lens. Now, how can one go about doing that? Where can we get education about taking that step?
So, basically, I think that we can start off with just like the legacy of race-based medicine. We can start off with the legacy of medical research abuse, right? And I feel like that is so very well documented in the literature. So, and there's just so many trainings on those very topics, right? I know I lead a lot of these trainings at GW, so and they're all free, and we actually offer CME, for clinicians to actually learn that history. And so you can definitely go to GW, like the School of Medicine and Health Sciences, our site, to actually get free self-paced courses on these very topics. So I think that's like just really important to kind of think through. But, I also think that, from that racial lens, it really does remind me of the story of Dr. Susan Moore. And for, your clinician audience who may not be familiar with who she is, or let me say who she was a Black woman who was also a physician who actually video recorded herself from the hospital bed, because she actually had a COVID diagnosis. And she wanted to literally document live her mistreatment from her care team, and literally like went viral, right? She was sharing how, they were dismissive of her symptoms, of her pain. And we know, again, speaking of being well documented, pain bias is very well documented in the literature. And that's coupled with this racist trope of being an angry Black woman. And that got attached to her because, in the video, you saw her asserting herself. She was advocating for her rights, but none of that was to her benefit, because, she ended up dying from COVID complications, despite being a doctor herself. And this is why I even opened with that. Like, okay, here I am, I got this degree and that degree, and I'm doing this and that. At the end of the day, none of that's protecting me, right? That didn't protect her. And actually, a recent article, actually a study, maternal mortality, just showed that the more money that Black pregnant women actually make, that the worse their birth outcomes. And so, and that's because this was never, only about poverty or lack of prenatal care, or you don't have a medical home, oh, you don't have health-seeking behaviors, oh, you don't have education. No, this has always been about racism. And so that's why I've just always been so passionate about just the enduring impact of racism on health. And like I said before, we're not going to eliminate health disparities without eliminating racism. So, clinicians really do need to tune in. And I know more and more clinicians are starting to have these conversations, self-educating themselves and not putting the labor on, their, colleagues of color, but self-educating yourself and seeking out this information is really important. There's lots of books, actually. There's like medical apartheid. I mean, there's like so many books that I can just like talk about. Like, I can give you a reading list. So if you want to add some show notes, I can literally send you a reading list. Sure. So I think that's just going to be just really super important.
We're talking to Maranda Ward. She's a clinical research assistant professor. Her Kevin MD article is titled Why HIV and COVID-19 Vaccine Screening Should Go Together. Maranda, tell us some of your take-home messages that you want to leave with the Kevin MD audience.
Oh, there was a lot of things that I learned. I know that just PCPs are just so inundated. And, let me just share that because, this is not about putting any blame on like PCPs. You should know better, right? You should know about this, that, and the other. I love the work that primary care general practitioners do, incredibly valuable. And we're partners in this, right? Me being like an educator and medical educator. And so, there's lots of pressure and you're like, literally general practitioners are getting hit up to do everything, right? Screen for depression, screen for substance use, screen for abuse. And now here I am also screened for HIV and COVID vaccine screening. It's a lot to hold, right? And I recognize there's, time constraints, there's, limited resources. It's, some clinicians actually feel like they don't actually have the, it's not in their wheelhouse to know about who's a candidate for PrEP. And they feel like that's the role of the infectious disease doc. So I will say the take-home message is that the primary care setting is the setting for primary prevention. Yes. Right. So specialists, they do, tertiary, and like they want to keep you from dying or get the treatment. It is this setting actually where we do need to have the conversations how to prevent HIV. So that does, testing is prevention, right? So this is the setting. Same thing with COVID vaccines. This is the setting to get those questions answered, to get them plugged into, resources and research opportunities. And, and I just feel like it's really important because like the health equity tracker that the Morehouse School of Medicine houses, and they literally have all of this data from CDC. So they're not they're not creating the data on their own. They're literally, collating it on their site. They literally show that, Hispanic patients, Asian patients, Indigenous patients are actually leading the nation in COVID vaccine rates. And I feel like media stories, narratives often paint the picture that people of color, and that's another thing, they lump us all together, that people of color, aren't out here, trying to, take the vaccine or have any health-seeking behaviors or pursue like COVID precautions. And that's just not true. And so, with them leading the vaccination rates, we know it's possible, right? So there's models there that show that they're not the hard to reach populations that they get, dubbed as. So I just think that, medical educators alongside, primary care clinicians can work together to really improve community and population health alongside individual patient health. And so I welcome your clinician audience to learn more about the work that we do. It's called the 2-in-1 model. They can go to our website, 2-in-1, all words, no numbers, .smhs, which is the School of Medicine Health Sciences, .gwu.edu. And you can also follow GWSMHS on all our social media platforms, and you'll learn about all of our free training webinars that offer free CMEs.
Maranda, thank you so much for sharing your time and insight, and thanks again for being on the show.
Thank you.